You on 8? You on 8. Okay, you're clear. Stand by for your base.
Welcome to EMS Cast, where we provide high-level education for you, the providers on the streets. My name is Ross Orpit.
And I'm Matt Mendez. Who do we have today, Ross?
My name is Martin Musi. I'm an emergency medicine physician at University of Colorado, and I'm pleased to be here.
Dr. Musi is the Wilderness Fellowship Director at the University of Colorado. He is also the Director of the Diploma in Mountain Medicine of the Andes, and he is the Medical Director of the Rocky Mountain Rescue Group and assists in both technical rescue trainings and active missions.
What are we going to be talking about with this beautiful Argentinian man today?
We're going to talk today about different relevant information regarding accidental hypothermia and how this is important for the EMS provider in general.
Dr. Musi just recently got together with some experts from the International Commission of Alpine Rescue to work on a paper that uses current evidence to suggest a revision to the Swiss staging system for hypothermia. The paper and its recommendations have been endorsed by the Medical Commission of the International Commission of Alpine Rescue and is expected to be put forth as a formal recommendation likely this coming October. The paper is currently under review for publication.
The revised Swiss system is, and the original Swiss system as well, is mostly intended for hypothermia, for pure hypothermia. Right? When you have, like, for example, I have a case the other day on a patient that arrived that was only responding to painful stimuli. His heart rate was around 100, and he came out of the bus stop. He was very cold, but he was also intoxicated. So their level of consciousness was also affected by alcohol. So basically, with our system, you will probably put them on a sicker category than his actual core temperature. His core temperature was actually probably 34.5. So he was even mildly hypothermic or normothermic, but felt very cold. Is problematic because, especially in the urban setting, hypothermia is many times associated with these conditions. But there's a couple of situations that can be used. For example, a kid that gets lost, an Alzheimer patient that gets lost, exposure to cold, and decreased level of consciousness can be associated with a higher risk of cardiac arrest.
Yeah, so tell us, why is this a topic that's important and relevant for us to know a lot about?
So first of all, hypothermia is very frequent in the urban setting as well as in the remote settings. But it also accompanies different medical pathologies and traumatic disorders and can have a huge impact in the morbidity and mortality of patients that suffers from hypothermia primarily, or they are complicated by hypothermia.
So obviously, I think we all realize that this is an important thing in the backcountry when somebody maybe gets stranded. But you're telling me this is important in urban environments too?
Yes, actually, hypothermia is one of the components of what is called the triad of death of trauma. So coagulopathy, hypothermia, and metabolic acidosis. And basically, when those components are present in the setting of trauma, that increase mortality significantly.
And is this something we only need to worry about in, say, the northern parts of the U.S.?
Hypothermia is one of those diseases or conditions that are of the ones that are exposed. And it's even possible to have hypothermia even in subtropical regions and tropical regions, especially when there is a combination of water and sometimes booze. Like boats and alcohol really increase the bar of the chances of hypothermia.
Fair enough. You also talked a little bit about the coexistence of trauma. Can you talk a little bit more about that?
Hypothermia-induced trauma is, as I said, very frequent, and it's one of those conditions that you can treat in the field. after vascular access and hemorrhage control in the setting of trauma, the management of or prevention or treatment of trauma-induced hypothermia is one of the things that you can do in the field to reduce mortality. So have it on the on the top priorities of your traumatic patients when you're assessing and treating those conditions that can increase mortality. But also you have accidental hypothermia primarily, right? You have those patients that can be found either after intoxication or secondary to psychiatric illness, that they are lost in the middle of the winter, either here in Colorado or in other cold states. And aside from trauma, primary hypothermia has a subset of clinical considerations and outcomes that are a little bit different from, for example, a patient that dies from cardiac arrest from, a cardiologic process.
Yeah, what are the differences in outcomes? What do we expect from somebody who maybe has a cardiac arrest from hypothermia?
So actually the prognosis of cardiac arrest secondary to accidental hypothermia is very different from your typical out-of-hospital cardiac arrest. There is different data and different methodologies of studies these in case series and in meta-analysis. But actually the survival rate for patients with accidental hypothermia can reach up to 70% when they are treated with advanced techniques like what we call ECMO or extracorporeal membrane oxygenation, in comparison to 15 to 20% as a goal for the out of hospital cardiac arrest secondary to cardiologic conditions.
Did he say 70%?
Yeah, that's pretty amazing, huh? That's why this is so important. These are patients that we have a real opportunity to save.
Probably should try to regularly pronounce environmental hyperthermia in the field then.
Funny you should mention that. Musi actually makes that point.
Yeah, so I think that, the mantra of nobody is dead until you are warm and death needs to have a very serious consideration in any patient that is suffering, especially from accidental hypothermic cardiac arrest. And we can go a little bit more in depth into what are the consideration of resuscitating someone versus just pronounce them in the field. As a general rule, for a pre-hospital provider, if you're close to the hospital and you suspect that hypothermia is the primary mechanism of why someone is in cardiac arrest, perform CPR and bring that patient to the hospital, because they are the patients that can walk out of the hospital with intact neurologic recovery from even prolonged periods of CPRs. We have cases of 6 hours, 4 hours of CPR plus 4 or 5 hours on the rewarming machine in the ECMO, and then walking out of the hospital with normal neurologic recovery.
That's amazing. So let's start here. Let's start with, what are the definitions of hypothermia?
So first of all, I want to stop here for a second. If you look at a map of the countries talking in Fahrenheit and the countries talking in Celsius, US is the only one talking in Fahrenheit. So, let's keep it up, America. We need to start talking in the right language that the entire world talks. So
we've never been much for followers.
Yeah. We're gonna talk Celsius here. So hypothermia, as a definition, is basically the decrease of the core temperature below 35 degrees Celsius. And this can be secondary hypothermia. Basically, you have an endocrine problems like hypothyroidism, or you're intoxicated with drugs, or you are under medications that prevent you from, having your thermal regulations set right. But those are very common causes of hypothermia. But basically, in all those conditions, you're gonna treat basically the underlying condition and not so much manage of hypothermia. And then you have primary hypothermia, which can be accidental hypothermia, homicidal hypothermia, or even iatrogenic hypothermia when we put patients on mild hypothermia after out-of-hospital cardiac arrest, right? So that would be the different classifications of primary hypothermia.
Why is it important for us to know these different definitions? How does this help us?
Well, secondary hypothermia, as I said, you treat the underlying cause and actually has a little bit, like more of a poor prognosis in comparison to primary hypothermia.
Are there any current tools we can use in the field to kind of help us for staging or classification?
Yes. So staging or classification of hypothermia is important for many, many reasons. Let's say that the most important way to classify a patient is by their core temperature. But obtaining a core temperature sometimes can be difficult. Not many, pre-hospital providers will carry thermometers. Obtaining a rectal a temperature or a bladder temperature is not really feasible in the field. And actually, the gold standard for obtaining a core temperature is basically a thermometer that you insert through the mouth or the nose on patients that are intubated on, providing an esophageal temperature. That's the temperature that is basically behind on the posterior aspect of the heart and provides a good estimation of what's the arterial or the central artery's temperature. Now, there's other tools that might be feasible to use in the field, like, for example, an ear thermometer. This is not the cheap ear thermometer that you buy at Walmart. It's a basically very sophisticated thermometer that functions as a thermistor and basically gives you a good idea of a core temperature when used properly. At the same time, there is some limitations on the using of ear thermometers or tympanic thermometers. For example, if you encounter a patient that is, submerged or has water or snow in the ear canal, you might be measuring lower temperatures than the actual core temp.
What's the current staging system?
So one of the ways to stage patients, especially in the field, when you don't have a core temperature or thermometer to measure a core temperature, is basically what was defined as the original Swiss staging system. In a position paper in 2003, the International Commission of Alpine Rescue came up with a system to try to classify patients based only on the clinical findings and not having a core temperature at all. They came up with five groups of patients from HT1 through HT5. In HT1, patients were conscious and shivering, and they estimate that their core temperature was in between 35 to 32. HT2, patients had an impaired consciousness, but they were not shivering. Basically, they exhausted all the thermogenesis potential of shivering, and now they are basically lying without responding, but also without shivering in the clinical findings. Those patients had an estimated temperature in between 38 to 28. In HT3, you have a patient that is unconscious, not shivering, but still have vital signs. And those patients usually have a temperature between 28 and 24. In HT4, patients had no vital signs, so they are already in hypothermic cardiac arrest. And then there was a fifth category that was removed in subsequent editions of the original Swiss staging system, is that due to irreversible hypothermia. Those patients had a temperature that was below 13.7. And that 13.7 was from a case of basically the record on how low was a patient with accidental hypothermia successfully resuscitated. We know now that, like every year and, everything about hypothermia is trying to find the lowest number. Last year in 2020, there was a case reported of a 23-month-old kid that got out of his house at 4 a.m. in the morning in Krakow, Poland, -7 C at night. Pretty mild temperature for Krakow at night. But the kid was found unresponsive in hypothermic cardiac arrest 500 meters from their house and had a CPR time of 2 hours. When he got to the hospital, his temperature was 11.8. And that kid was successfully resuscitated and now has a normal life with normal neurologic recovery. So basically, they decided that the lowest number of someone that can be resuscitated from hypothermia is still unknown.
That is amazing. So when he got to the hospital, his temp was 11 degrees Celsius, which means it started out much lower than that because he was probably in a warm ambulance on the way.
Yes, 11.8 was when he was placed on ECMO. But, who knows? At the same time, that is the lowest recorded temperature. In hypothermia, it's a little bit, everything is about the world record, right? So far, I don't think that we have seen lower temperatures than those.
Okay, so the new classification staging system, or the Swiss model, we've essentially removed the irreversible hypothermia from that staging because we don't know what temperature that is.
Yeah, so that the evolution of the original Swiss system, this was in 2003. A lot of, a long time has passed. So that was the original Swiss system and kind of the evolution over the last 10 or 15 years. Now, there is recent data that is showing that the accuracy of the Swiss system might not be all that good. There was 2 studies, 2 retrospective case reports that in total came up with 305 patients when they're trying to assess the correlation of the Swiss staging system with a recorded core temperature. The results of that of those studies shows that the Swiss staging system correlates well with the core temperature in 61% of the patients. And then there was 18% of patients that were, where the temperature was overestimated, and 21% of patients where that temperature was underestimated.
So it sounds like the Swiss staging system was accurate in its temperature prediction only 61% of the time. That's really not much better than flipping a coin.
Yeah, and there are consequences to over and underestimating, right?
If you overestimate the temperature, your patient is classified colder than he or she really is and might lead to unnecessary treatment, unnecessary monitoring, maybe, transferring that patient to, a higher level of care that you need. But if the patient is classified warmer than she or he really is, this can, you might transfer that patients to an improper facility where they cannot do, advanced rewarming of that patient. So, that really risk of 21% of underestimation is, what we are looking, in the, in the International Commission of Alpine Rescue as, maybe there is a potential for harm on those patients. And we are working currently with a group of co-authors to try to redefine the Swiss staging system on what we call the revised Swiss system.
So what you're telling me right now is that the physical exam findings that we used to rely upon with the Swiss staging does not actually correlate all that well with the actual temperature of the patient. And the actual temperature of the patient is what kind of correlates with their risk of having an adverse outcome.
Yes, and that's a major determination. Of course, risk of cardiac arrest is very variable among your population, right? Maybe someone that is fit, like an alpinist that gets, stranded in the mountain, with a core temperature of 30 or even 28 might not have, might not hit the risk of cardiac arrest until you're super low. If you have someone that is very frail, an Alzheimer patient that, gets lost in the middle of the winter in Colorado, then that patient have risk of cardiac arrest even with a little low upper temperature on 32. Even with mild hypothermia can have, a cardiac arrest. So it's a little bit of determined by the patient, but also, one of the most important determinations for the risk of cardiac arrest is the temperature.
So, if the current system isn't much better than flipping a coin at predicting a temperature, but temperature is the best predictor for cardiac arrest, how do we move forward?
Well, this is the exact question that Musi set out to answer with his group.
So we identify with a group of authors what are the limitations of the Swiss staging system, of the original system. And, one of the things that we identify is that basically that the language that was used on the original system, conscious, impaired consciousness, is not very clear, right? So we're trying to see if we can correlate it with other types of, scales for mental status, either the GCS or the APU score, to try to simplify the language and try to get it, get it right among a large population of providers. Another limitations that we found is that basically on the original Swiss system, you can be classified. You have two variables, right? You have conscious and shivering. And basically, what about if a patient is shivering but is unconscious? In what category do you put them, right? So basically, this brings the possibility of placing those one patient in two different categories. Shivering is a little bit tricky, shivering is pretty variable between patients. Right, you can have someone that is shivering with even a mild drop in the temperature, and you can have patients that can shiver even below, the expected 32 degrees, which will be your cutoff for hypothermia. So actually, we decided that shivering is important for trying to identify what's the thermogenesis production of an individual patient, but it's not longer a stage-defining sign for the new Swiss or revised Swiss staging system. And I think that the most important change that we are looking to make is that instead of trying to estimate what's the core temperature of a patient in the field, why we don't try to estimate what's the risk of hypothermic cardiac arrest and try to, leave the numbers when we have an esophageal thermometer and, more technology or advanced technology to tell us a little bit more about the, core and, leave the pre-hospital providers with a little bit more hard outcomes in terms of what are we really estimating.
I like that. So we're moving towards a much more pragmatic approach for our pre-hospital providers. Can you just summarize kind of the proposed changes to this for our pre-hospital providers?
Yeah, I think that the most important change is trying to change the focus from estimation of the temperature to estimation of the risk of cardiac arrest. The second change is that we're trying to see which one of the scales already used in other conditions, GCS, APU, are proper for a simplified, unified definition of stages by, the level of consciousness. And third change, we are removing shivering as a stage-defining sign because it's very variable. We're still is important to know this information, but knowing that if a patient is shivering, their core temperature is probably above 30, but still you can have shivering in other patients that might have a lower temperature.
We often talk about with hypothermia this risk of the cardiac membrane being desensitized to arrhythmias, and that sometimes you have to handle these patients with kid gloves because if you jar them or move them too much, that you might send their heart into a fatal arrhythmia. Is this true? Is there any data to support this? And if so, what can help clue us into that this patient might be at risk for that?
From a pre-hospital provider, you arrive to a patient, right? They fell on a ditch, right? And they are unconscious or minimally responsive. They have been, out for a significant period of time. It's cold outside, it's snowing. You should move that patient very, very carefully. And when you're moving that patient even to the gurney in the hospital, patients that are unconscious or patients that are minimally responsive have a very low temperature. And they get there kind of progressively low. When you move them and create a jargon and moving around, their risk and their myocytes at the cardiac membranes is very unstable. If you took them out of that stability, the risk of BFib arrest is high. So basically, careful transport and handling in any unconscious patients because of the low threshold of developing ventricular fibrillation.
What about the risk during intubation for developing one of those arrhythmias?
It's definitely real. There's a bunch of pre-hospital logistic troubles with hypothermia. One of those is you can by the motions of intubations and preparing the patient, you can put the patient in ventricular fibrillation. Also, there's a bunch of other stuff that can happen. For example, if you inflate the balloon, with your number of cc's that you should as per your tube recommendations, and you start rewarming the patient, the air that you place inside the patient is initially cold because of the surrounding cold tissue, and then you start rewarming that patient. That balloon can expand in the trachea and actually perforate the tracheal cuff. You can have super frigid muscles like trismus-like rigidity on the jaw, and it's difficult to intubate these patients. You can have decreased drug metabolism, secondary to meds for RSI, or even in patients that are already in cardiac arrest. We know that the ALS drugs don't metabolize as well in patients that have hypothermia. So usually, if someone has a hypothermic cardiac arrest, I try to decrease the dose of the medications that I'm giving, and I'm giving them less often than in a normal cardiac arrest. So, for example, I will double the time or decrease 50% of the dose when I'm managing hypothermic cardiac arrest, and I wouldn't go crazy until the patient has a temperature above 30.
Let's dive a little deeper into that. So how are you treating hypothermic cardiac arrest differently than our standard pre-hospital cardiac arrest?
Super interesting. If you have let's say that the patient arrived unconscious to the hospital without vital signs. That's a stage 4 for either the old or the new Swiss staging system. And then you have a patient with cardiac arrest. You intubate them and you had a terrible time because of very rigid muscles. The drugs for RSIs were not working. Maybe you can relax them, but they're metabolized for those drugs, especially in cardiac arrest, is going to be close to none. And then you intubate them. You put an esophageal thermometer. The esophageal thermometer should go at least in the middle third on the lower third of the esophagus, as close as the heart as possible. Then you have a reading on the temperature. If the temperature is below 30, probably you're gonna go with lower doses and longer times for your ALS protocols. And then you can attempt defibrillation if patient has a shockable rhythm. But if you perform 3 defibrillations and the patient is still in BFib arrest and the temperature is below 30, the chances of having successful defibrillation are pretty low. End-tidal CO2 can be a little bit misleading, can be used for tube placement and for very low numbers to indicate that patient is going or is in cardiac arrest. But there is some differences on the arterial PCO2 and then tidal CO2 that you get. So the numbers are not exactly what you're seeing on your blood levels.
So we can still use it. We can still use that end-tidal CO2 to confirm that our endotracheal tube is indeed in the lungs, but it's not necessarily going to correlate with our arterial blood gas.
Correct. Another thing super important, I think that this is a key concept for pre-hospital providers. Patients with hypothermia will have a decrease on their heart rate, a decrease on the respiratory rate, and decrease on their blood pressure that is linear in relation with the temperature. So patients can be extremely bradycardic and still have a pulse, right? So in those patients, take the respiratory rate and heart rate, especially on a central location, carotid, femoral, or even if you have a Doppler, or like in case that you have an ultrasound, take it for at least a minute, even a minute and a half. And if you go and try to, like check your pulse for, like a minute, is a long time. Maybe your fingers, if you're walking in the street or the mountains, are gonna be cold, so it's difficult to identify vital signs in these patients, and these patients appear dead, and they might not be dead until they're warm and dead.
All right, wait, pause. Is he suggesting waiting for a pulse for 1 full minute before starting resuscitative efforts?
Yeah, this was a crazy new concept for me too. Right? We always talk about the sooner the better. The longer you're off the chest, the worse the outcome. But in someone with suspected hypothermic cause of their unresponsiveness, they may be incredibly bradycardic. And furthermore, they still have good outcomes even with delayed or prolonged CPR. So initially, you may check a pulse for longer than you would in someone with a suspected cardiac or respiratory cause of their arrest.
Yeah, take your time. Those patients arrive there very, very slowly. And even prolonged CPR or even delay CPR, and we're going to talk a little bit more about this in a few minutes, but basically those patients arrive very, very progressively to that state. So you don't need to rush anything. You need to be careful about putting that patient on cardiac arrest. It's better to have 4 beats a minute than none.
So you talked a little bit about how if somebody's below 30 degrees Celsius and they're not responding to shocks, that maybe they're not going to respond to shocks until you warm them. In the pre-hospital setting where we may not have a temperature, if somebody's gotten a round of ACLS medications and they've gotten maybe a couple of shocks and they're not responding, would you recommend just pausing until you get to the hospital and further rewarming efforts occur?
I think so, yes. Unless you have a very high suspicion that this is not, that the primary mechanism is not hypothermia, and it's more of someone, like was shoveling snow, had a MI, had cardiac arrest, and now they're a little bit cold. And in that case, maybe you are looking at, pronouncement. But if you're looking at primary hypothermia, then, the problem is that also, maybe not so much for shocks, but for drugs, you can have, if you rewarm them, now all those drugs are in the system right now, and now you have a massive amount of epinephrine. Maybe the patient has even frostbite associated with hypothermia, and now you have complicated, the courses of other diseases, right? So if it is not going to work, you can try a couple of times, but I wouldn't get fixated on it.
Matt, can we take a second and just review for the listeners kind of your ACLS considerations when it comes to a hypothermic arrest?
When it comes to ACLS modifications during cardiac arrest caused by hypothermia, in other words, low body temperature, the things that I consider is if the patient is less than 30 degrees Celsius, I will not use any epinephrine or any other drugs, and that's pretty standard practice across the board. Once you get in between that 30 to 35 degrees Celsius level, if you are going to give ACLS medications, you want to double the dose interval. In other words, we typically say 1 milligram of epinephrine every 3 to 5 minutes. You'll want to give that anywhere from 6 to 10 minutes after your first dose. When it comes to shocking VFib, you can do that at any temperature. There's a pretty good chance it won't work below 30 degrees Celsius, but you are well within your right to try up to 3 times if they are below 30 and they are in VFib. If they're still below 30 after 3 shocks, I will just keep warming them and focus on other things rather than shocking them. When it comes to bradycardia as part of hypothermia, that is often an expected rhythm, and I would not pursue pacing or atropine until they are at least above 32 degrees Celsius. And even then, you'd have to convince yourself pretty good that the reason they're bradycardic is because they have a heart problem and not just because they're hypothermic. In the end, I would not pace bradycardia in a hypothermic patient in the pre-hospital setting.
Yeah, check your own agency's protocols, but oftentimes the protocol will be something if hypothermic arrest is considered, you do one round of ACLS medications and then wait until you get to the hospital, but that will be protocol specific. So if we're in the hospital, temperature is less than 30 degrees, they're not responding to ACLS meds, they're not responding to shocks. What do we do in the hospital to warm these patients such that they're at a temperature that they might respond to these things?
First of all, you need to think if the patient is, the mantra is nobody is dead until warm and dead, but there is actually a couple of patients that are just dead. They're cold and dead. If they have lethal injuries, if they have a rigid chest, if there is rescue safety, more from the pre-hospital providers, we discussed about the lower number that we encounter. But of course, if you have like a temperature of 5, maybe you want to go for the world record, but it's going to be difficult, right? If you need to rewarm that patient to, normal. Is there asphyxia as part of the cardiac arrest? So patients that, have hypothermia, but also, have drowning or hypothermia or have asphyxia from an avalanche burial in the wilderness setting, then, those patients don't have as good neurologic recovery or as good survival as your primary hypothermic patient without asphyxia. And there's some considerations for potassium use as basically a surrogate for asphyxia and, a surrogate for potential for recovery. We had an investigator from Switzerland created this HOPE score, which is hypothermic outcome prediction after ECLS. And basically you can go online, look it up. You can plug in the different values. They take in considerations age, gender, if the hypothermia is associated with asphyxia or not, how many minutes of CPR you had, what's the serum potassium, and what's the temperature by an esophageal temperature. And then it gives you an estimation of what's the potential for survival of that patient. So, for example, if you plug in a 22-year-old that doesn't have asphyxia, a male with a temp of 22, then that patient has probably a likelihood of survival of 58%. You drop a potassium of 10 there, and that number drops from 58 to 23. Still super good, right? If the percentage of survivability is less than 10%, then you should consider if that patient should go into ECLS or not. But still, that will be depending on your cardiothoracic surgeon, your ECLS team. But, more than 10% is better than, it's almost as close as out of hospital cardiac arrest, right?
Yeah, that's a good point. You talked about, I think you alluded to this earlier, about some changes in ACLS and CPR and maybe delayed or even intermittent CPR. What the heck are you talking about here?
With hypothermia, cardiac arrest being one of those conditions that have, a good neurologic outcome, and from data coming in from cardiothoracic surgery where they, stop the heart for, a significant amount of time, to case reports of patients that actually receive delayed or intermittent CPR with good neurologic outcome. Basically your brain, if it cooled down before asphyxia or before hypoxia, your brain is protected, right? So, even periods of intermittent CPR, right? We are talking about someone in the middle of the trail that, is in hypothermic cardiac arrest and you need to evacuate that person from a difficult situation or location. Moving that patient for 5 minutes and doing, and stopping and doing 5 minutes of CPR, it might be, all they need. And there have been a couple of case reports that are published on resuscitation on patients that have intermittent CPRs where they move for 5 minutes and then CPR for 5 minutes, or move for 5 minutes and then have, a CPR period of 10 minutes, depending on their temperature, that had good neurologic outcome. So now with, like Stampers, like with a cardiac CPR machines, like maybe you will have a patient that can have a very low temperature. You put them in one of those machines and you try to rewarm them, because even with intermittent CPR, like they can have a good neurologic recovery. I think it's pretty fascinating to think about, stopping for 5 minutes on the chest and not providing compressions and still have a patient that, can survive.
Yeah, we push so much in cardiac arrest care, continuous high quality CPR. But if you can't get that person out of the elements, then you're never going to be able to warm them. And if you're never going to be able to warm them, you're never going to be able to get their heart to respond to your shocks or your ACLS medications. So at some point you have to get them out of the environment. And sometimes to get them out of the environment, you have to stop doing CPR. And what you're telling me is there's some data to suggest that's okay. You can stop CPR for a few minutes, move, restart CPR, and that way you can intermittently keep moving, keep doing CPR, and people can still have good survival.
Yes, in that publication, they if the temperature was below 28 C, CPR was delayed by up to 10 minutes to allow rescuers time to move to a safer location. If the core temperature was in between 20 and 28, they perform at least 5 minutes of CPR and 5 minutes without CPR. And if the core temperature was below 20, they perform at least 5 minutes of CPR and less than 10 minutes without CPR. And, basically those patients survived. There are a few case reports and a few cases translated from animal studies and from, cardiothoracic surgery. And it's not, like super hard data on it, but it's still a concept that, these patients, even with periods of perfusion, they can still, survive and have a meaningful neurologic outcome.
Wow, that goes against everything we preach in ACLS, where the biggest focus is on continuous high-quality CPR and minimizing interruptions.
It does, but remember, this is in primary hypothermic arrests, in less than ideal situations. So if you're a rescuer in the backcountry with someone who arrested from hypothermia, you got to get them out. No one's coming to you. They're not bringing the ECMO machine to you. This is data that supports it's okay in that patient to stop CPR for a bit while you make your way out of the backcountry. Now, if you're in an urban environment, not much is different other than primary hypothermic arrest patients do better at the hospital where they can be put on something like ECMO and actively rewarmed rather than staying and working them on scene. So in the primary hypothermic arrest, it's okay to pause CPR for a minute to move to the ambulance, but as soon as you're able, you do still want to get back on the chest and stay on the chest. So we've gotten them out of the field. We've managed to extricate them from the cold environment and situation. Can you talk a little bit about aggressive rewarming strategies and then what hospital of choice we should be thinking about for transfer?
First of all, you said it right. You took them out of the elements, right? Make sure that your patient is not in contact with, cold surfaces. It's important not to miss more heat, right? It could be the difference between going into like your, 30.5 of temperature. You don't have a way to measure it, but all of a sudden you open up the chest, like you let the air or the heat in the ambulance go down because you open a door, and then all of a sudden that patient is newly exposed. You can drop one, C, and then that patient can snap into cardiac arrest. So make sure that you are preventing any further heat loss. Then, you have different ways of rewarming someone. You have passive rewarming and active rewarming. Passive rewarming is basically when you are attempting to use the patient's thermogenesis, capabilities to create heat. And those are more for patients that are in mild or maybe moderate, but like starting to be on the moderate side of things. When someone is in cardiac arrest or in severe hypothermia, there's no thermogenesis production by their body, right? So you're gonna need to actively rewarm them. If that patient is still shivering, you can, like passive rewarming with, layers. Make sure that you protect them from the environment. There is a very useful tip that is, if the patient is shivering and is cold with cold and wet clothing, you can put what we call a vapor barrier really close to that wet barrier instead of like unrobing that patient and taking all their layers out. So that basically creates a layer when like the amount of moisture gets equalized, and those patients will at least preserve some of the energy that they are producing.
Can you just define the differences between passive rewarming and active rewarming?
Yeah, so passive rewarming, you're using their own, thermogenesis production, shivering, for generating heat, but you need to try to fight against the other stuff that, takes heat out of you. You are, conduction, you are, isolating them from the snow or from a cold surface. You are, guarding against wind, which is your convection mechanism for heat loss. There's not much thing that you can do about evaporation. Patients are going to be still breathing, but you can reduce radiation by putting different layers and decreasing the amount of energy that they are expelling to the air.
So passive rewarming, we are preventing further heat loss. We're preventing cold elements from getting to them. Active rewarming, we're actually going to be attempting to add heat to their own system, their own body. How do we do that?
Correct. That can be external or can be internal. In terms of external, you can think about, like water bottles that are heated, making sure that you're not burning your patient. There's different type of exothermic devices that they basically come in as different blankets that you can open, similar to a hand or toe warmer, and they can get activated with the oxygen in the air, and that generates an exothermic reaction and liberates heat. Also, you can, there's different devices in the hospitals like your bear hugger and your, kind of your external devices. That can be operated by power, can be operated by an exothermic reaction. There are some military applications for stuff that gets activated with charcoal. So different ways to, bring heat to the body externally. And then you have active internal rewarming. And that's when you get into more aggressive resuscitation. One of the most commons is going to be, IV heated fluids, right? You can heat fluid to, 42 degrees Celsius. Usually we try to use dextrose plus normal saline. The reasoning is you want to give some calories to that patient to be, if you don't have calories, you cannot burn and you cannot generate heat. And we try to avoid lactate because seems that there's not like super good data on it, but cold divers are having some difficulties on metabolizing lactate. So we try not to give LR to these patients. Also, you can if you have blood and it's a trauma patient, you should heat that blood about 38 degrees because you can create hemolysis. But at the same time, whenever you are giving IV fluids, IV or heated IV fluids to someone, the degree of heat generation that you can create with that is pretty minimal. It's 1 C per liter of heated fluid, and you have a range where you can get that amount of heat gain. But be careful. Try to, if you have a long tubing, there's going to be a lot of radiation of that heat. So make sure that you curl your IV tubing. Maybe you can put a heat pack in between those and use like line tubes that are as short as possible.
Matt, can you take a second for us and just summarize passive rewarming in the pre-hospital setting for us?
Yes, the first step that you're going to want to do is when you're able to, you're going to want to remove the wet clothing and dry the patient as much as possible. This is often done in the next step of passive rewarming, which is get the patient to a warm environment, which for us is going to be a heated ambulance. So once you're in the heated ambulance, cut those wet clothes off, get the patient dry, and then the next step is going to be to insulate the patient so that when they lose their body heat, it is trapped by the blankets that you've warmed them in, and that causes them to reheat themselves. If you have one of those aluminum foil space blankets, this is amazing for this too, and you can pack even more cloth blankets on top of that to prevent as much heat loss and insulation as possible.
And then you get into the more aggressive ones, right? We can do mucosal irrigation, which is basically GI or bladder irrigation. You can get 1 to 2 Cs an hour of heat with that. Usually, probably in the hospital, we wouldn't warm the fluid more than 45 C because you can create some mucosal thermal damage. And then you get into the very, very, very aggressive one, which is visceral irrigation, either pleura or peritoneum, where you put an anterior chest tube and a conventional chest tube, and you just run heated water to 42 Cs through the chest, especially in the left side where you can kind of bath the heart. And these are very sick patients probably waiting for ECMO, or maybe this is the only way that you can rewarm someone in your shop. But there is some cases of survival with cardiothoracic lavage, and there is some data on a peritoneal lavage as well. I think that we as emergency physicians are not as comfortable providing peritoneal lavage, and I'm more prone to put chest tubes for this type of patients. You can perform hemodialysis as well. And then there is a couple of catheters that are named intravascular devices that are cooling or warming. I think that one of those brand names are the Alcius, which you need very expensive equipment, a big machine that goes next to the patient and connected to a central line basically that has a resistant on it, and you can warm that patient intravascularly.
Great, Matt. So that's active rewarming, which oftentimes is going to be done in the hospital. But so our listeners have an understanding of it, can you just break it down and summarize it for us once more, Matt?
Active rewarming as it pertains to the pre-hospital setting is going to be simple things like heated pads or heated water bottles. Some agencies might have a way to do some of these forced air warm blankets, or the brand name that we use around here is called the Bear Hugger. Another thing that some agencies might have is a way to have warm IV fluids, which is, of course, an active rewarming that could be done in the pre-hospital setting. Then you start to move into the stuff that's going to require at least some type of facility, emergency room or hospital, like warm baths or lavaging the inside of the body. So putting a chest tube in and warming up the chest cavity, putting a catheter into the peritoneum and warming up the abdominal cavity, putting a Foley catheter in the bladder and warming up the lower bladder and the genitourinary system. And then the final, most aggressive active rewarming possible is going to be ECMO, which Ross is about to ask Musi about.
What about ECMO for these patients? Can you talk a little bit about that?
So ECMO is actually the preferred method of rewarming patients that are in cardiac arrest, secondary to hypothermia, or patients that have hemodynamic instability secondary to hypothermia. You can reach numbers of like up to 1 to 2 Cs in like 5 minutes, and can be VA ECMO or AA ECMO, so arterial ECMO or venous arterial ECMO. As like if you just Google like a patient in ECMO, you can see like the amount of material, the amount of resources that you need for generating something like that. But at the same time, again, these are patients that have much more better recovery or neurologic recovery than any other type of patient. So why we cannot use a perfusionist and an ECMO machine to really change the life of someone that is maybe healthy, maybe young, and has a good chance of making it out of the hospital in good shape.
What about these central venous cannulation devices that can be used to rewarm people? Here at our hospital, we use something called the Alceus catheter. Can you tell us a little bit about that, Matt?
Yeah, basically, if the patient doesn't meet criteria for ECMO, but they need to be rewarmed aggressively, we'll put in a central line that has pretty long balloons on them. Those balloons can hold a high volume of water. And so that central line is then hooked up to a machine that circulates hot water through those balloons, thereby warming the blood in the venous system and therefore warming the whole body.
So we've briefly mentioned it a bunch of times throughout this episode, but this idea of ECMO, which is probably the most advanced type of care that we can provide for these hypothermic patients, but honestly has been the biggest game changer in regards to improving the survivability of hypothermic patients in hypothermic arrests. Matt, can you break down simply exactly what ECMO is for our listeners?
ECMO is a machine that lives outside the body, and 2 catheters are placed in the patient's biggest possible blood vessels so that all of the patient's blood supply can be taken from the body, run through that machine, and then given back to the body to the patient. In terms of hypothermia, what's happening in that machine when this is done is that the machine is rewarming the blood. And this can be done at anywhere from 9 degrees Celsius per hour to sometimes even higher rates than that. So you can imagine how quickly you can get a patient back to physiologic levels of rewarmth. The way ECMO is used in other diseases is anything where you need to fix something in the blood, whether that's temperature, oxygen, the amount of carbon dioxide, or poisons. Oh, and I almost forgot. ECMO stands for extracorporeal membrane oxygenation. One more time. Extracorporeal membrane oxygenation, ECMO.
What about the patient who maybe didn't go into cardiac arrest, was extremely hypothermic, showed up to the hospital or your ambulance, you started your passive or active rewarming, and now you've gotten them to a higher temperature. There's this phenomenon with their blood pressure where you suddenly might see a drop in their blood pressure. Can you talk about that a little bit?
Yeah, you can see changes on their hemodynamics, and you can see changes on their core temperature as well. One of the a very known and described phenomenon is what we call the rescue or circumrescue collapse of patients that are, maybe having a lot of cold blood on their extremities, and as soon as they start moving or start to mobilizing all that cold blood into the core, they can have like a lower lower of their core temperature. And basically it is a phenomenon that is also known as after drop, in terms of like dropping the temperature, as soon as you start rewarming them, is very common.
All right, that was some phenomenal review and information. Can you take it home for us? Can you give us some take-home points, something we can take to the streets, just summarize what we talked about today?
Logistically, caring for a patient with primary hypothermia is difficult. Think about scene safety first. You're exposed to the same elements, right? Especially if you're working on kind of more of the remote side of things. Second, do not, those patients arrive there slowly. Don't go crazy on trauma mode. Be gentle, take your time, take a heart rate and a respiratory rate for at least a minute. Really determine if your patient is as sick as you are, as you think. Is this patient in cardiac arrest or not? Of course, if they have, 4 beats per minute, they're still very sick, but they're still not in cardiac arrest. Think about the mantra of nobody is dead until warm, and death is pretty true. There is certain conditions that maybe not, and there's new tools to decide which patients are gonna be, having a chance of survival. You as a pre-hospital provider, if you suspect primary hypothermia as the cause of someone in cardiac arrest, transport them to the hospital with CPR in place. If you cannot do CPR all the way, don't worry too much. The hard and fast, high quality CPR might not be as important in hypothermic patients. Then think about the different tools that you have for estimating the risk of cardiac arrest in the field based on the level of consciousness, which is one of the things that correlates with core temperature. Think about, like the evolution of these things and how this is going to change. We probably will need to readjust the Swiss staging system at some point to add some other components like vital signs. And then tools for rewarming. Make sure that you're not losing more temperature. Make sure that there is, if you have someone with, like they have mild or moderate hypothermia, they're still having thermogenesis production, passive external rewarming, and move to active external rewarming and active internal rewarming when those patients are sicker. Transport them to the hospital, but prevent them from losing more heat. If you give them a NS solution that is at 21 degrees Celsius on a patient that has 25, you are creating more hypothermia. So maybe less is better in those situations.